Those are the main functions. So I will describe the organizational structure of the anti-malaria campaign, how the organization is being spreaded in headquarters as well as in the regional offices. And I will briefly discuss the trend in mobility and mortality of malaria in Sri Lanka and what is the current situation now. And third one, I will describe the functions and responsibility of the line ministry, mainly our headquarters and the regional malaria officers. And finally, I will tell you briefly the link between the regional malaria office and the provincial health system. So describe the organizational structure. Yeah, actually this is a vertical campaign, anti-malaria campaign. So we are under the health ministry, line ministry, actually under the Minister of Health and the secretary there, DGHS there, and under we have DDG, PHS and Public Health Services Son, who is responsible for the mainly the communicable disease. And under that, we have the direct anti-malaria campaign, and we have mainly 4 technical units. One is vector control unit, case management and parasitic control unit, training unit, and the surveillance and M&E unit. So under each section, we have consultant medical physicians. So then we have for the vector control, we have entomologists and medical officers. And under the entomologists, there are EAs, PHFOs, and spraying machine operators. Especially the case management, mainly diagnosis and case management and follow-up. So we have a separate medical officers, and we have pathologists to involved with the mainly the diagnosis part. And training, yeah, we do train parasitology, entomology, and especially the case management and also the surveillance part. So we have a separate training unit, and M&E, mainly the data handling, so feedback and also collection of data, systematic collection of data done by another section. So this is the organizational structure. And other than this line ministry, we have a separate regional malaria officers which are under the provincial council. So under the provincial council, there is a provincial director of health services, and under him in each district there are regional directors of health services. So in districts under this RDHS, we have regional malaria officers, and they have separate staff. Under the regional malaria officers, they have entomological assistants, HCO, health entomological officers, public health field officers, PHIs, and a lot of staff. Earlier, they were very, very strong, but after the now elimination, most of the staff now have been allocated to the other sections, but still the regional malaria officer is the head of the malaria activities in each district. So other than that, medical officers of health are there. So roughly we have 360 MOHs. So in each MOHs also do malaria control activities with the request of the headquarters and the regional malaria officers. So other than that, there are hospitals under the provincial council. In the hospitals, mainly the diagnosis part, case management part, and the follow-up part are being done. So the vision is a malaria-free in Sri Lanka. So our vision changed because in 2016 we got the malaria elimination certificate. That means 0 indigenous cases were there since 2013. So we got the malaria elimination certificate in 2016. So then we changed our visions, strategies, and missions. So vision is, so after the elimination, now we are in the phase of prevention of reintroduction and re-establishment, which means if any indigenous case reported, that is mean reintroduction. But if several cases of indigenous cases reported after the elimination, that is mean it is re-establishment. So our main target is to prevent reintroduction and re-establishment. So we have a separate strategic plan, and in the strategic plan, there are many activities to maintain this zero morbidity and mortality. So objectives to prevent reintroduction, yes, as I said, and to maintain zero mortality due to malaria. So the second objective to discuss the trend in morbidity and mortality of malaria in Sri Lanka, and to discuss the current situation. So we know that we had malaria for centuries, but we have data since 1911, and we all know that there was a huge outbreak of malaria in 1934-35 era. Almost 82,000 deaths were reported, and 5.5 million cases were reported in this era. And government did many activities and could achieve a huge reduction of cases. But after the introduction of DDT in 1946, the number of cases drastically, rapidly decreased, and in 1963, almost 17 cases, only 17 cases were reported, and out of them, 11 were imported cases. So, government and even the World Health Organization wanted to declare Sri Lanka as a malaria-free country, but while the cases were very low, as any government do, the funding, the human resources, and other prevention activity, surveillance activity were curtailed, were reduced. Because of that, in 1967-68 years, there was a outbreak reported in Kataragama and Matale, and that resulted almost 40 years of malaria epidemic in Sri Lanka. So almost 500 to 700,000 cases were reported in each year. And 1987, the recent largest outbreak happened. So almost 1 million cases were reported. But with the technical support from the GFATM, Global Fund for the Tobacco, Malaria and AIDS, WHO, and other government and non-government organizations, and the effort of our health staff, especially the anti-malaria team, we could achieve 0 deaths in 2007 and 0 indigenous cases in 2013. So as you can see, in 1999, almost all the country had malaria. Country mean in each districts had cases of malaria. But in 2012, only very few areas reported the malaria cases, and in 2012, only 23 cases are reported. After that, no indigenous cases. These are indigenous cases. Indigenous cases mean the patient gets the parasite from another mosquito. That means spreading from one person to another person. So you can see that, last is 2007 and last number of cases reported in 2012. Then usually we have to wait for 4 hours to get the malaria elimination certificate from the World Health Organization. So in 2016, we got the WHO malaria elimination certificate from the World Health Organization, and Sri Lanka is the only country in Southeast Asian region who got malaria elimination certificate. Not Singapore, not Malaysia, not Thailand, not Indonesia, not India. So it was a huge success, especially the public health achievement to get this malaria elimination certificate. But do we have a risk? Can you say, okay, now we have eliminated malaria, so we don't need to worry. We can allocate our staff to the other campaigns and we don't need so much fund? Are we repeating the history itself, which we experienced in 1963? No. Why? You can see that Sri Lanka is in the equator. There are several countries which is above the equator and the below the equator. Almost all countries are dark brown, which means one or more indigenous cases are reported. Especially that China also had malaria, but this year, last year, China got the malaria elimination certificate also. So other than that, almost all the country, the Southeast Asian region, malaria, and those are malaria endemic countries. So several people from Sri Lanka, especially gem businesses, especially for the Madagascar, and there are several factories installed in African countries, especially the garment factory, hydropower projects, and lots of our people go there and work there. And people go to India for the pilgrimage, and Thailand, Malaysia for tours. So, and from these countries also, especially as the asylum seekers, refugees from India as trade, and from African countries, especially for the tours and also for the trade and businesses, they come. So there is a huge migration from Sri Lanka and to Sri Lanka, which means although the elimination we have eliminated the malaria parasite inside the body. That doesn't mean we eliminated the entire mosquitoes who are responsible for the spreading of disease. So we are sure that no one in Sri Lanka having malaria parasite inside the body. That is, we have eliminated. But if someone brings the parasite from this country, then mosquito there. So always there is a risk of spreading that mosquito to bite that infected person and spread that parasite to other person. That's why we are saying always we are at higher risk, although we don't consider malaria as a major disease, major burden. So in world, yes. So malaria case per 1,000 cases, 81 in 2000 and 59 for 2020. Not much decrease. And also the cases from 30 to 15. 50% as reduction seen, but there are lots of things to do in the worldwide. And lots of people get the malaria from African region and India. Almost 95% cases are from African region and India. And as well as the deaths also mainly from Nigeria and the Congo, but most of the countries are African countries. Although I say that 2012 we had only 23 cases. So then after we didn't have any indigenous cases, but that's not true because in 2018 we had a introduced case. That means foreign person came here, Indian person in Monogala, he got malaria. That means the parasite came into their blood from the liver and he was bitten by a mosquito in Sri Lanka, and that mosquito spread the disease to another person and he got malaria. That means there is he is an indigenous cases, mean the introduction. So we had a reintroduction in 2008. So we are mainly now focusing on prevention of re-establishment rather than re-introduction. So although we get 0 cases since 2012, we are getting imported cases since 1900, and still we are getting imported cases. So in each year we get around 50 to 60 cases, especially from India and the African region. But last 2 years due to the corona, we had few number of cases. In 2020, only 31 cases, and 2021, 26 cases. So in 2022, this is strong. This was for the 18th of February. but for the 31st of March, we got 12 number of cases. All are imported cases and all are from African countries. So this is the map of the number of the country of origin, mainly from India in 2018, and others are from African countries, mainly the tribe forces. Also now we are getting increased number of cases from the tribe forces who are going to the peacekeeping missions. So this is the Sankey charts. So as you are students, I think it's better to you to know this Sankey charts because very descriptive, this kind of charts. So here in the left side, the number of countries, and in each country, we can get an idea how many patients reported from each country. So we know that in 2020, 1 Israel and 4 India, all the other, and 2 from Pakistan, all the other from African countries. And on the right side, we know that we can, there are four parasites who are responsible for that 30 cases. Plasmodium vivax 10, Plasmodium falciparum 8, and Plasmodium ovale 8, and mixed 4. So consider the imported malaria, most of the cases. Now, if you can remember that map I showed you from 1999 to 2013. So almost all the areas were dark brown, and most of the cases were concentrated into the northern, eastern, and northwestern and north central provinces. But now the imported cases are mainly found in western province, southern province, and central province. Why? Because most of the people from this area go to these African countries and other countries where malaria is there and get the disease. So this is 2018. Yeah, this is the first and second objective, mainly the organizational structure and the trend in morbidity and mortality. So then, okay, now we know that we have a very higher risk of getting malaria again. So what are we doing as anti-malaria campaign? What are the things that we do? Before that, I think I would like to reiterate to describe some parts of our this epidemiological triad. So for to have the disease, the environment, host, human as the host, and the agent, parasite, are responsible for this triad. So other than that, being a vector control, vector-borne disease, vector also responsible for spreading the disease from one person to the another person. So mainly the environment, host, and the parasite. So intermediately there is a vector. So what can we do to control, to break this cycle? One is we can break the cycle from the environment to human, like environmental modification, environmental manipulation, and do some changes into the environment. We can change mainly the vector breeding to prevent the vector breeding. That is the environment to human. Usually the environment to parasite, no, we can't do anything, but human to parasite, we can break it, and human to vector, we can break. Human to vector, we can mainly break on mainly the personal protective equipment. Equipment mean methods like wearing long sleeves and applying repellents and LLINs, like those things. Or we can destroy some parts of vectors and their larval stage by chemical or biological methods. So we can control, we can break that cycle. But the easiest way to break the cycle from the human to parasite, which is by drugs, mainly the chemo, therapeutic drugs. So function, when you call the functions and responsibilities of the directorate, yes, we do the diagnosis and treatment. We are the ones who do mainly the confirm the diagnosis and guide the hospitals to start the treatment. And parallelly, whenever we get a patient, we do that is reactive. Whenever we get a patient, we do pathological surveillance and entomological surveillance. But proactively, not reactively, proactively, before even we are getting the cases, we do pathological surveillance and entomological surveillance to prevent occurrence of any disease or else to identify anyone who are asymptomatic. So pathological surveillance and entomological surveillance have been done. So if needed, yeah, if we found that there are mosquitoes, vectors there, yeah, we do the vector control. Other than that, our main responsibility is to aware the public, especially the undergraduate like faculties, and also doctors, clinicians, and other paramedical staffs, and the public care staff, and also the public. So we are doing lots of activities for the public awareness. And the administration and financial management we do to make sure that all the resources are available in the places where necessary. So these functions, not only the line ministry headquarters, also the regional malaria office also, to some extent, all of these parts, they also do. So diagnosis and treatment, here we don't treat the patient by our own. There are proper guidelines and proper directives on how to manage and how to treat the patient. So we have two guidelines, main guidelines. Scope of work, SOW. When a malaria patient is reported, it clearly mentions what to do, what are the things that you have to do, how to prepare, how to act on it, what are the things that you have to do. All the things, even documentation and surveillance, all the parts are there. So you can download these guidelines from our anti-malaria campaign website. So other than that, especially targeting the hospitals, mainly the treatment, we have separate guideline for the treatments. This is the scope of work. This is, both are there. In the left side, scope of work, in the right side, treatment guideline. And we have updated it, and now the second version, version 2 is available in the web. So in the guidelines, mainly it says when to suspect malaria, how to do the diagnosis, how to do the notice, how the case investigation. When the case is there, we are individually, in each case, we are individually analyzing, and we do the pathological and entomological surveillance activities to find out whether he has spread the disease to others, or whether the vectors are there who are responsible for the spreading of disease. So we make sure he has not spread the disease to any other person. So other than that, we do the follow-up in the sense, we do screen them in a given frequency to make sure that he has no relapses, recrudescences, or any other parasite which have hidden inside their body. 1 minute, please. So, all the patients, so the how to do the early diagnosis and case management, all the patients with fever and a recent travel to a malaria country should be tested for malaria. That is the most important part. When to suspect? When a patient comes with a fever who has a travel history for a malaria endemic country within last year, yes, you have to suspect him as having malaria unless proven otherwise. So any patient suspected having malaria should be immediately notified, and it should be notified to the headquarters and the regional malaria officers, because we have many things. We have to guide them. All the treatments are with us, and the diagnosis, confirmation of diagnosis is done by the regional malaria officer. So the notification, early notification, we don't wait until 544. usual notification happen. We ask them to inform us over the phone. We have a hotline which is working for 24 hours. So we ask them to inform us over the phone whenever they get a patient, even at 2 a.m. Yes, sometimes they call and within 1 hour, we start our treatment. So the any febrile individual, including foreign nationals, history of with the history of recent travel to a malaria endemic country, yes, you have to suspect malaria. So other than that, if someone has unexplained fever, which is PUO, belongs to a risk group. If someone in a suppose a group of army officers came from African country after peacekeeping mission, if someone gets malaria, we consider all others are at risk of having malaria. So we check all the members of that risk group. So others having features of severe malaria, unexplained anemia, yeah, those are straightforward. And the early diagnosis is the most important part. So when suspected malaria is notified to the anti-malaria campaign, we confirm the diagnosis. So how to confirm? There are two methods. One thing is RDT, rapid diagnostic test, and the other is microscopy. So microscopy is the gold standard, but the rapid diagnostic test is very easy to perform, and it doesn't need an expert person. This is the microscopy. We take two sides. One is thin film, another thick smear. So based on the findings, we confirm the species, the stages of that, the number of parasites inside their body, all are measured by this microscopy. So this is the rapid diagnostic test. So it's like the RAT for COVID. So we just put blood drop for solution, and we get the results within 20 minutes. So the parasitological surveillance. So when we diagnose patient, yes, we are doing active, reactive surveillance. Whenever we get a malaria patient here, we have to start to find out whether there is anyone who has got the disease around this home. So usually around 500 kilometers, 100 houses, or within 1 kilometer, we do a parasitological surveillance. We do take the blood smears, and then that I'll bypass this one. So entomological surveillance. So other than that pathological surveillance, we do entomological surveillance. Entomological surveillance means looking for the mosquito vectors. So we have in Sri Lanka, we have primary vectors and secondary vectors. Usually the primary vector is Anopheles culex. So he's the most responsible mosquito for the spread of malaria. So we have 5 secondary vectors, Anopheles group, like Anopheles subpictus, tessilatus. Yeah, there are 5 types of secondary vectors. So we check whether there are adult mosquitoes. There are techniques to find out whether there are adult mosquitoes, and we check whether there are larvae in the surrounding area, usually within 1 kilometer radius. So we do sometimes we do have this entomological surveillance for 5 days, and we do all the testing, and we get a report saying that whether there are adult mosquito or larvae there, and what are the types of mosquitoes and their behaviors. We are getting all these details. So based on these details, we are thinking what kind of vector control methods we have to do. Usually in a malaria, the areas where mosquitoes are found, usually in northern area, eastern area, and northwestern and north central. Yes, if the mosquitoes are there are some conditions. So we have to apply IRS, insecticide residual spraying. And sometimes we have to provide long-lasting impregnated nets, LLIN, for the entire neighborhood. And also sometimes, depending on the situation, sometimes we may have to do fogging to destroy all the adult mosquitoes. And for the larvae, yes, we are applying some chemicals. Sometimes we have to do some environmental modification or manipulation like flushing the area, those things also we do as vector control methods. So like reactive entomological surveillance, usually we start within 48 hours, and the parasitological surveys, the screening, usually we do within 24 hours. So these are the available malaria vector control strategies, and most here the vector control have been targeted for the vector, the mosquito, the parasite. No, this is not vector control. These are control strategies. So there are control strategies targeted for the vector, targeted for the parasite, and targeted for the environment, and targeted for the human. Mainly the control strategies for the vector, yes, we have mainly the second part, indoor residual spraying. We do the indoor residual spraying, and for the larvae, we do larval source management. Like I said, some applying chemicals or things, and fogging, area spraying. For the parasite, yes, mainly the treatment, case management, and we don't do intermittent presumptive treatment or mass drug administration. And here also we don't give seasonal prevention because we don't have malaria. So mainly the case management to destroy the parasite, and the environmental, environmental management and house improvement, and for the human, personal protective measures and behavioral change communication, which is the most important part, behavioral change communication to change their behavior. For the public awareness, yes, we do some clinician program, and we go to their districts, and we collect some doctors and the clinician who are responsible for managing these patients and the public care staff, and we do awareness programs. So, malaria office and the provincial extreme. What is the link? Yeah, we have one under provincial system. We have regional malaria officer. So we are technically responsible for the regional malaria officer. So we usually communicate with some monthly review, quarterly review, and annual review. We do have communication with them, financial, financial guides. So RM although is in the technical inputs are taken. So those are the things that I wanted to highlight mainly. So other than that, I will briefly describe. I just skipped that slide. Yeah. So whenever I said that, when we diagnose that patient from the microscopy and RDT, yes, we have to, because as we get very few cases, they should be treated only in the hospital. Those should not be treated at the OPD setting. So uncomplicated, yes, our treatment is different. If it is severe disease, our treatment is different. And also the treatment is different by the species of parasite. If it is Plasmodium vivax, yes, we do start chloroquine, but if it is Plasmodium falciparum, which are resistant to the chloroquine, especially the African, mostly African, brings the Plasmodium falciparum. We can't start chloroquine, so we do start ACT, artemisinin combination treatment. So our management varies between the complication and the species. So that's why, as the most of the doctors who have not seen any patient in their service period, they have to inform us and they have to communicate with us to have the proper management. So we usually communicate with the consultants and the medical officers and other staff in the hospital, and we guide them for the proper management of this patient. So management is most important. And after 3 days, if the parasitic count 0 only, we can discharge the patient. But after the discharge, he is completely free of malaria parasite inside his body for the Plasmodium falciparum. We do weekly parasitic count. So we ask them to come to the hospital and get checked. First week, second week, third week, fourth week, sixth week. Up to 42 days, he has to come. And if it is Plasmodium vivax, because as there are liver stages, we have to screen them monthly up to 1 year. Like first week, second week, third week, fourth week, sixth week, then monthly up to 1 year for further follow-up. So those are the follow-up mainly. So that is done for the individual patient, and also the our in the surveillance part. Usually we have in each month we have a case review committee, CRC, and each and every cases separated there and find out whether there are any gaps, whether there are anything that we have to improve, and we just communicate with this detail with the regional malaria officer at the monthly RMO review. So in each month we are in the RMO review, and we just communicated our activity and their activity and discuss the situation, current situation of malaria control activities. Those are the main activities that have been done by the malaria campaign. So although you may be thinking malaria is not more there, so we don't need to worry about malaria. No, we have to worry because there is a huge risk of getting malaria as imported cases, and the malaria vectors are there in Sri Lanka. So always we are at risk. So whenever a patient comes with a fever, with the travel list to 1 year, travel list to endemic country within last 1 year, yes, you have to suspect the patient as having malaria. So those are things I had to mention you. So thank you very much for attending this lecture. So I hope that you have taken some understanding on malaria control activities done by the headquarters and the regional officer. So thank you very much. I think now you have dengue, no? Mr. Kishan, Mr. Kishan's phone is not, the mic is not working. So shall I leave the leave from the Zoom session? Hello. Did you hear me? I am thinking whether for the last 45 minutes I just talk to a people who can't speak and who can't hear.
Sir, we heard you, sir.
You heard me, no? Oh, yeah.
Sir, I have. If I ask.
Then I think dengue, no? You have dengue. I think Madam Nimalka Pandiretti might have joined.
So we have the non-communicable disease.
Yes, all these are non-communicable disease. Yeah. Vindya. Oh, Vindya Madam has she joined now? Not yet, no?
No, sir.
So what to do?
Sir, shall I ask questions?
Yeah, definitely. Yeah, sure.
Sir, if they ask for challenges in the current anti-malarial campaign, what can we say, sir?
Challenges mean the mainly thing is now funding part. I already told that the funding has declined. The human resource part has been declined. They have been shifted to the other campaigns. That is the usual thing. And the other thing is still we are having a high risk of because lots of migration are there from Sri Lanka to these African countries and from these countries to Sri Lanka. The problem is we can't screen them at the airport. The main thing is if we can screen them at the airport, a reasonable amount of people who are infected, we can identify.